Today's topic is a very important one, thyroid disorders in pregnancy. We do come across, at least in our normal OP, endocrine OP, we come across 20 to 30% of pregnant ladies coming with abnormal thyroid function. So what we have to remember here is that in pregnancy, we are not just treating the mother, we are treating the growing fetus also. So the drugs which we are giving, either thyroxine or even anti-thyroid drugs, they are crossing the placenta. So we should be very careful when we are treating thyroid disorders in pregnancy. So before going on to the topic proper, we should know about the physiological changes in pregnancy. We all know that the women's body undergo a lot of changes in pregnancy. And this is true with respect to the thyroid axis also. So in pregnancy, after the implantation occurs, we know that from the syncytial trophoblast, we have increased production of HCG. So this HCG peaks around 12 weeks. The HCG, it slowly peaks around 12 weeks and comes down. So during this time, you see that the TSH going down in even normal individuals. So what we have to know here is that HCG and TSH, they have molecular mimicry. So both the molecules, both HCG and TSH, they have an alpha subunit which is similar, a beta subunit which is somewhat similar though different. Okay, so the HCG in high amounts can stimulate the thyroid receptors and increase the thyroid hormone production. So that is why we see that when the HCG is increasing, even in normal individuals, there is a small fall in TSH and a rise in free T4. Simultaneously, because of the increase in estrogens, there is increase in the thyroid binding globulin or the TBG, which results in increased total T4 in the circulation. Also, the thing to note is that the fetus is dependent on the maternal thyroxine at least up till 18 to 20 weeks of gestation, where the fetal thyroid gland develops and becomes functional. So during pregnancy, you can see that there is an increase in 50% in the demand for thyroxine. So this thyroxine, the maternal T4, is directly transferred to the fetus. The HCG is helping with this respect. The HCG is causing the TSH receptors stimulation and increased hormone production. The TBG is allowing for more binding of the T3, T4, and in the circulation. Also, the thing to note is that the placenta has an enzyme known as type 3 deiodinase. So the T4 is degraded by this deiodinase enzyme. Hence, the woman requires more T4 hormone in circulation. Also, because of increased plasma volume, there is increased maternal clearance of iodine to the tune of 30 to 50%. So and even the iodine is transferred to the fetus to produce thyroxine in the fetal thyroid tissue. So, but all these factors result in high iodine requirement by the mother. So, in women coming from iodine deficient regions, we should supplement with them with extra iodine if we are suspecting iodine deficiency. Another thing to know is that because of the TBG increase, the T3 and T4 I said would increase. So by around the second or third trimester, you will see this peak out, and the T3 and T4, you will see that it is above the normal range. So if the upper limit of normal for T3 is 200, you can, if you are testing for T3 or T4 in pregnancy, you can multiply this by 1.5. So a cutoff of up to 300 might be normal for T3, cutoff of up to 18 might be normal for T4. So the best test in pregnancy would be a free T4 if you are actually looking at hyperthyroidism patients or thyrotoxic patients. Also, as I said, the TSH in pregnancy, it comes down a little bit, and you can keep a cutoff of normal as 0.2 in the first trimester, the lower limit cutoff as 0.2, and for the second and third trimester, you can keep it as 0.3. So, thyroid screening during pregnancy, the international guidelines actually do not recommend universal screening, but they recommend screening for ladies having thyroid disease history, lobectomy, postpartum thyroiditis, a family history of thyroid illness, someone having goiter, thyroid antibodies, mainly the thyroid peroxidase antibodies, someone having frank symptoms of hypothyroidism, people having autoimmune conditions like type 1 diabetes, celiac disease, etc., women with infertility, head and neck radiation, or history of miscarriages. However, our Indian society, the ITS, Indian Thyroid Society and FOXY 2019, they recommend screening all pregnant women with a TSH in the first visit. So TFT interpretation, we all know. So the main test we look at is TSH. So when there is, uh, sorry, when you look at TSH, if you see that the TSH is on the upper limit of normal, you look at T4. So if the T4 is low, this is classical hypothyroidism. And if the T4 is normal, this is subclinical hypothyroidism. Again, if the TSH is low and the T4 is coming on the higher side, this is this is frank hyperthyroidism. And if the T4 is coming normal, this is subclinical thyrotoxicosis. Now, coming to our first case, this is a very common scenario that we come across. This is a 25-year-old primate, 7 weeks of gestation, asymptomatic except for tiredness, no goiter. Routine investigation shows abnormal thyroid function, and this patient is referred. So here the TFT the TSH comes at 74, and we all know that 74 is quite high for any test. So free T4 also you can see it's on the lower side. So this patient has frank hypothyroidism. So how do you treat this patient? So definitely there is no doubt you have to start thyroxine, levothyroxine therapy. Hypothyroidism in pregnancy is defined as a TSH above the upper limit of the trimester specific range. Isolated hypothyroxemia is also commonly seen in pregnancy, where you have a normal TSH with a low free T4 in the 2.5 to 5th centile. So why are we worried about hypothyroidism, overt hypothyroidism per se? So hypothyroidism results in miscarriage, pregnancy loss, low birth weight, gestational hypertension, preeclampsia, increased risk of premature birth. Even lower IQ in the offsprings are seen in untreated mothers having hypothyroidism. So this I had touched upon in the beginning. So if you see that the neurological development of the fetus starts by around 5th week, and it is only by around 12 weeks that the thyroid gland starts developing in the fetus. The thyroid hormone production just begins by 16 weeks, and it is only by 18 weeks that the fetus produce enough thyroid hormone. So up till this time, the fetus is dependent on the maternal thyroxine and specifically the T4 in the circulation, because this is the one which crosses the placenta. And this old study by Haddo in NEGM showed that children born to mothers with hypothyroidism, specifically untreated hypothyroidism, had an IQ that was 7 points lower than women who are euthyroid or who are treated adequately for hypothyroidism. How do we treat thyroid disorders in pregnancy? So it is levothyroxine alone. Now we have a lot of other preparations, especially levothyronin or T3. So this levothyronin, you should know that it doesn't cross the placenta. So hence it is not recommended to give T3 in pregnancy unless in specific circumstances. Desiccated thyroid hormones not available in our part but available in Western countries should not be given. The dose for treatment for overt hypothyroidism, it depends on the degree of TSH elevation, the symptoms, etc. So in this patient that I discussed, the TSH was 74. So 74 is quite high. In normal individuals who are having hypothyroidism, we usually treat with a dose of 1.6 microgram per kg. But in pregnancy, because you are treating both the mother and also covering for the thyroxine requirement of the developing fetus, you need to give a higher dose. So you need to give around 2 microgram per kg in this case. So if this lady is say 62 kilogram, you give 62 into 2, that is 124 or approximately 125 microgram that we have in the market. And then you test the thyroid functions after 4 to 6 weeks. So once you start treatment, the goal is to keep the TSH below 2.5 in the first trimester, below 3 in the second and third trimester. And it is even recommended to keep it at the lower half of the trimester specific range, or I would say roughly between 1 to 1.5. But anything less than 2.5 in first trimester, less than 3 in second and third trimester is good enough. And TSH should be monitored every 4 to 6 weeks. Another important scenario that we come across is women having infertility or history of abortions. So in these women, if you see that the TSH is on the higher side, even if it's normal, you can consider treatment of these women with levothyroxine to bring the TSH to below 2.5. Also, in women who are previously treated with thyroxine, you can increase the dose so that the TSH comes to below 2.5. Always in women of childbearing age groups, when they come to you for routine follow-up of hypothyroidism, you should ask them whether they are having a plan for pregnancy in the future. So always advise them that if they conceive, come back to you immediately for a thyroid function test. And if they are not able to, at least increase the dose by 20 to 30 percentage. So if someone is taking 100 micrograms of thyroxine, ask them to make it 125 micrograms once they find out they are pregnant and come back to you for a repeat thyroid function test. Or what you can do is, instead of the 7 tablets that they take per week, you can add 1 or 2 extra tablets of thyroxine. So suppose they are taking 50 micrograms of thyroxine, 7 tablets, 7 days a week. So you can make it 50 microgram, 8 tablets a week or 9 tablets a week. So you can add 1 tablet extra in a Sunday or a Saturday, like that. So regular monitoring every 4 weeks, as I said. So we'll come to postnatal monitoring in the later slides. So the second case, this is a 25-year-old trainee, 7 weeks into gestation, asymptomatic, no goiter, routine investigation, again comes out with a high TSH of 7.4, a free T4 in the normal range. So you see here that the TSH is 7.4, above the upper limit of normal, which usually for the labs is around 4. And what do you do in these circumstances? So usually in non-pregnant patients, we can decide on treating or not treating these patients. But in pregnancy, we specifically look at the thyroid peroxidase antibody. So in this patient, the thyroid peroxidase antibody was strongly positive, more than the upper limit of detectable, more than 600. So this is a case of Hashimoto thyroiditis, which requires treatment in pregnancy. So why do we treat subclinical hypothyroidism? Again, subclinical hypothyroidism is not as problematic as the frank hypothyroidism, but it does carry an increased risk of pregnancy loss, preterm delivery, and placental abruption. Also, these adverse effects are more in women having TPO antibody positivity. There is no data or very limited data to show that treating subclinical hypothyroidism will improve the IQ of the offsprings. So coming to the TSH cutoffs, which we use to decide whether a patient is having hypothyroidism. So we should have our own trimester specific reference ranges. So these reference ranges are derived from pregnant ladies who are TPO antibody negative and also coming from iodine sufficient region. Unfortunately, we don't have any big studies from southern part of India. This is a study from Tertiary Care Hospital in Haryana, where they looked at pregnant women with normal thyroid function test and a normal TPO antibody and who are iodine sufficient. And they found that the upper limit for TSH can be kept as 3.6 in the first trimester, 4.4 and 4.6 respectively in the second and third trimester. But the ATA recommends that unless you have a region-specific cutoff, you can keep a cutoff of 4. So any women in our part, especially in Kerala, coming with TSH more than 4, we can label them as having subclinical hypothyroidism, uh, especially if the T4 is normal. So coming to thyroid autoimmunity, why it is important, especially why do we look for TPO antibodies in pregnancy? Because this is associated with a 4-fold increase in miscarriage and a 1.7-fold increase in the premature deliveries. So women who are TPO antibody positive and the TSH even slightly above the upper limit, better to treat these individuals. So this is in crux on how to treat subclinical hypothyroidism in pregnancy. You can take a screenshot of this and I'll make it simpler in the next slide. So any woman having a TSH more than 10, you have to treat irrespective of the TPO antibody status. And any woman having a TSH less than 2.5, no need of treatment. So values between 2.5 to 10, when to treat. So coming to our case scenario, TSH more than 4 and less than 10 with TPO antibody positive, better to treat. Second, if you're having any individuals with TSH between 4 to 10 and TPO antibody negative, you can still consider treatment. No harm in considering treatment. And women having a TSH between 2.5 to 4 with TPO antibody positive, again, you can consider treatment considering the benefits. Okay. Again, if you have a lady with TSH between 2.5 to 4 and TPO antibody negative, then no need of treatment. So again, this is a simplified version. You look at TSH in pregnancy, more than 10, you start treatment, less than 2.5, no treatment. Between 2.5 to 10, go for a TPO antibody. If TPO antibody is positive, you treat the patient. If it is negative, and the TSH is between 2.5 to 4, there is no requirement for treatment. If the TSH is more than 4, bit less than 10, you can consider treatment. So again, treatment of subclinical hypothyroidism is with levothyroxine, and the starting dose is usually lower than that we give in frank hypothyroidism. So you can start somewhere between 25 to 50 microgram, again depending on the symptoms and the TPO antibody status and the TSH levels. Again, the goal of treatment is to keep the TSH below 2.5 in the first trimester and below 3 in the second and third trimester. Ideally, the TSH should range in the lower half of the trimester specific range, and you should do frequent monitoring and, if needed, dose adjustment every 4 to 6 weeks. Now you have treated a woman with hypothyroidism in pregnancy. So what will happen after delivery? So if a woman had pre-existing hypothyroidism and you had increased the dose in pregnancy, you need to bring the dose back to the pre-pregnancy dose after delivery. Very simple. Now, if someone is newly diagnosed with hypothyroidism in pregnancy, like our first case where the TSH is more than 74, it is unlikely to resolve. But in women having mildly elevated TSH, like between 4 to 10 with TPO antibody negative, and taking a lower dose of thyroxine less than 50 microgram, it might be possible in these women to stop thyroxine. However, if you are stopping thyroxine, always monitor the thyroid function test after 6 weeks. In women having TPO antibody positive, they are likely to have Hashimoto thyroiditis and some level of hypothyroidism. Hence, monitoring is the key. You can definitely reduce the dose, but might be that you might need to continue the a low dose thyroxine after delivery. Now coming to the opposite spectrum, the thyrotoxic or the hypothyroid spectrum. So this is the third case. This is a 26-year-old lady. She's a primey at 12 weeks gestation, coming with a 3 weeks history of nausea, vomiting, and palpitation. And she has weight loss of 2 kilos, not tolerating solid foods, requiring antiemetics, IV fluids. So this is a classical case of hyperemesis gravidarum. On examination, this lady has mild hand tremors, a pulse rate of 104, which is common in pregnancy. Thyroid normally palpable, no bruit. When we look at the TSH in this patient, it comes suppressed at 0.02. The T4, this is the total T4, is at 18 microgram per deciliter. As I said earlier, usually the upper limit for the labs are 12 or 14 in most labs. So this comes within the normal range. So if you're keeping the upper limit as 12, 12 into 1.5, this is the total T4. So up to 18 is normal. Or you can go with a free T4 measurement. So this lady has a subclinical hyperthyroidism or a subclinical thyrotoxicosis. So do you treat or will you choose not to treat? So this depends on what condition the lady is harboring. So what is overt hyperthyroidism? So in these conditions, you see that there is a low TSH, a high T3, T4. So this is overt hyperthyroidism seen in 2 in 10 pregnancies. This is associated with fetal loss, fetal growth restriction, preeclampsia, and preterm delivery. Rarely, it can result in thyroid storm and congestive heart failure. Subclinical hyperthyroidism is again very common. It's more common than overt hyperthyroidism, seen in up to 2% of all pregnancy. And the thing to note is that subclinical hyperthyroidism is usually well tolerated by the mother and the fetus. So usually you will not be needing to treat these patients. So coming back to our patient, she had TSH suppressed, T4 in the normal range, which is subclinical hyperthyroidism. So we will not treat the patient whatever the etiology would be. So coming to hyperthyroidism etiology, we will discuss about this main etiology, which is TSH receptor stimulation in more detail. Then the hyperthyroidism can be due to autonomous thyroid hormone secretion, which can be from toxic multinodular goiter, solitary toxic thyroid nodule, or a congenital activating TSH mutation. It can be a destructive thyroiditis like Dickrovitz thyroiditis. It can be extrathyroidal source, the most common being iatrogenic over replacement of thyroxine in pregnant women having hypothyroidism. So coming to the most common etiology, the excess TSH receptor stimulation in pregnancies. So this is caused by two main conditions, I would say Graves' disease and pregnancy-associated transient hypothyroidism. Trophoblastic disease, which results in increased HCG, can again stimulate the TSH receptor, though this is rare. So in our patient, which we discussed, the most common etiology is to distinguish between Graves' disease and pregnancy-associated transient hyperthyroidism. So how do we do that? So coming to one second. Yeah, coming to how to differentiate between both the conditions. Usually, Graves' disease patient will have a family history of thyroid illness. It can be hypothyroidism or a hyperthyroidism in the family. The gestational thyrotoxicosis usually doesn't have a family history. Again, Graves' disease can occur in any trimester of pregnancy, but the gestational thyrotoxicosis or the pregnancy-associated transient hyperthyroidism is seen in the first trimester. MSS again results due to increased HCG and as in our case, this woman had hyperemesis gravidarum, increased HCG with stimulating the TSH receptors, causing the gestational thyrotoxicosis. Again, multiple pregnancies can increase the HCG level and cause the gestational thyrotoxicosis. Usually, the classical feature to diagnose Graves without lab test is the orbitopathy or the dermopathy or the diffuse goiter that we usually see with Graves. This is usually not seen in transient hyperthyroidism. The clinical signs are usually, it can range from no symptoms to clinical hyperthyroidism. Usually, the gestational thyrotoxicosis has very mild or absent clinical signs. And the most important test that we do is the TRAP test, TSH receptor antibody test, which is positive in Graves' disease and negative in gestational thyrotoxicosis. The Graves' disease is usually progressive in the first trimester and needs treatment, whereas the gestational thyrotoxicosis, they are a self-resolving condition. And also, a thing to note is that gestational thyrotoxicosis is 10 times more common than Graves' disease. So it doesn't mean that you assume that a pregnant lady having subclinical thyrotoxicosis or a slightly in the overt hyperthyroid range is gestational thyrotoxic. You should always investigate, look at the family history, look at the trend, how that thyroid function is going. Usually the gestational thyrotoxicosis resolves. Look at other signs like orbitopathy or dermopathy, which points towards Graves. Look at the TSH receptor antibody test, also which points towards Graves. You require treatment, whereas the gestational thyrotoxicosis doesn't require treatment. So the investigation which you should do in any pregnant lady having thyrotoxicosis is a TSH receptor antibody test. And why this test, I will come to it. This test costs somewhere between 3,000 to 4,000 rupees in our part, but this helps us to determine the etiology and also follow up these patients, and also very important because TSH receptor antibody very high in mother can result in neonatal thyrotoxicosis in the infant. Now, indications for doing a TRAB antibody for diagnosis of Graves' disease or fetal thyrotoxicosis in pregnant women, you do a TRAB test in all women who are treated hyperthyroid or Graves' disease to know the level of the TRAB antibodies, or even in newly diagnosed pregnant women. Also, it is very important that you do a TSH receptor antibody in women who had a previous history of Graves, which was treated by either surgery or radioiodine ablation, because the TSH receptor antibody might still be present in the circulation. It can cross the placenta and cause neonatal thyrotoxicosis. Again, women with a previous history of delivering an infant with hyperthyroidism should have a TSH receptor antibody test done. So the treatment of Graves' disease, I think we all have a knowledge of this. It is basically medical management, radioactive ablation, or thyroidectomy. Radioactive ablation is not an option in pregnancy. Thyroidectomy is usually considered in women who are resistant to thyroid hormone, antithyroid drug treatment, especially who are being given high dose antithyroid drugs, still uncontrolled, or who have some allergic reaction or intolerance to the antithyroid drugs, or pregnant women with thyrotoxicosis having suspicious thyroid nodules, you might consider thyroidectomy. Other than that, you always go for antithyroid drug treatment in pregnancy. So the main drugs that we use in pregnancy are methimazole or carbimazole. So methimazole is the active drug. Carbimazole gets converted to methimazole in the body, and PTU. And the thing to note is that if you are having a Graves' disease patient, either pre-existing Graves or newly diagnosed in the first trimester, there is an exacerbation in the first trimester because of the increased HCG levels. So there is more stimulation of the TSH receptor because of the HCG and also because of the TSH receptor antibody. And you might require a slight increase in the antithyroid drug dosage. Usually, like all autoimmune conditions, in the second and third trimester, you will find a decrease in the thyrotoxicosis and decreased requirement of medications. And most of the times, we see that in late second trimester or third trimester, we are able to taper the antithyroid drugs and stop them. Again, after the delivery, there is there is a recurrence of the symptoms, and therefore proper monitoring and treatment might be required. Coming to the drug treatment, which is mainly with methimazole or PTU, the thing again to consider is that these drugs, methimazole and propylthiouracil, both cross the placenta, and both can result in some embryopathy or teratogenicity. The most common seen with methimazole is dysmorphic facies, epilepsy acutis, choanal or esophageal atresia, abdominal wall defects, umbilicocele, and rarely VSTs. So it's seen in infants who are exposed, so in children who are exposed between 6 to 10 weeks of gestation, and the prevalence is to the tune of 2 to 4%. PTU, though deemed safe, has mild birth defects like facial and neck cyst and urinary tract anomalies, which are usually asymptomatic. So this is a photo of a child with epilepsy acutis. So epilepsy acutis is basically focal absence of the epidermal or sometimes the dermal tissues, which you see like this. So because there is teratogenicity with these drugs, we should always be treating the women adequately even before pregnancy. So any women, just like in hypothyroidism, you tell them to take the tablets correctly and to increase the dose after delivery. You have to monitor the thyroid function test, monitor thyroid function test of women with Graves' disease. Try to make them euthyroid even before pregnancy. If a Graves' disease patient has conceived, you immediately shift from methimazole or carbimazole to PTU, which is relatively safer in the first trimester, and then you shift back from PTU to methimazole after 16 weeks of gestation. See, methimazole is more associated with teratogenicity like epilepsy acutis and choanal atresia. So you want to avoid these and shift from methimazole to PTU. But the problem with PTU is that it is hepatotoxic. So you don't want to continue PTU for a long period of time. So you shift from PTU to methimazole after 16 weeks of gestation. Again, the treatment target is different in women have in Graves' disease in pregnancy. So you have to monitor these women every 2 to 4 weeks, at least 2 weeks in the beginning. And once the thyroid function is stable, you can monitor every 4 weeks. And the thing to note is that you should monitor with a free T4 and a total T4 in the beginning. So you should try and keep the free T4 at the upper half of the reference range. So suppose your lab free T4 reference range is say 1.8. So you try to keep the free T4 at 1.8 or around 2. You should not bring it lower than that, because when you are, this means that you are over treating. This means that this drug, the methimazole or the PTU which you are giving to the mother, it is crossing the placenta. And in the fetus, it can cause hypothyroidism. So always target a T4 or free T4 at the upper half of reference range. In resource poor settings, as I said earlier, those who have only total T4 as an available tool, you can multiply the upper limit of normal, say it is 12 by 1.5, which comes to 18. So you can keep the T4, total T4 at around 18 microgram per deciliter, or maybe 19 or 20. And usually the mother and the fetus, they can tolerate subclinical thyrotoxicosis better than frank thyrotoxicosis. So as I've said earlier, TRAB should be tested in all women with history of Graves' disease, be it previously treated with ablation or surgery, or undergoing current treatment, or newly detected. Why so? Because the TRAB antibodies, they cross the placenta. And once they cross the placenta, they can stimulate the fetal thyroid to produce more hormones, which can result in fetal thyrotoxicosis. So even in asymptomatic women, we need to ask about history of thyroid disease. Suppose a woman had undergone thyroidectomy a year back for Graves' disease and is coming with pregnancy, coming pregnant now. You have to check the TSH receptor antibody at the beginning of pregnancy and at around 18 to 22 weeks. And if you are finding that the TSH receptor antibodies are more than the 3 times the upper limit of normal, usually the upper limit of normal for most labs is 1.7 to 1.8. So if you are finding a value more than 5 or more than 3 times the upper limit of normal, there is a high chance of the fetus having neonatal thyrotoxicosis. So again, you repeat after 30 to 34 weeks. In these situations, this is the only situation where you can use a block and replacement therapy, where you can give thyroxine to the mother and give antithyroid drugs so that it can prevent high thyrotoxicosis in the infant. So coming to neonatal thyrotoxicosis, so as I've said, this is because of the TSH receptors which were transferred from the maternal blood to the fetus. The TSH receptor antibody is IgG antibodies. They have a half-life of 2 to 3 weeks. The onset of symptoms in neonatal thyrotoxicosis is between 2 to 10 days. They are usually very mild and self-limiting, but it can result in severe thyrotoxicosis and even heart failure and failure to thrive. So you have to keep monitoring these patients. The neonates having symptoms, you have to treat with methimazole, with or without a beta blocker. Usually the dose of methimazole is between 0.2 to 0.5 mg per kg. You have to monitor the thyroid function in these cases every week, because as the immunoglobulins, the IgG antibodies come down in the fetus, the thyroid function returns to normal, and you don't want the fetus to go into hypothyroidism by your treatment. So you have to frequently monitor, and you have to frequently taper the dose of methimazole. And usually neonatal thyrotoxicosis resolves by 3 to maximum 6 months. So coming to our last case for the day. So this is a 26-year-old lady. She's coming postpartum 3 months. This is the first visit. She's coming with a weight loss of 2 kgs. TFT done in pregnancy was normal. However, now she's experiencing tremors of her hand, a pulse rate of 104 per minute. The thyroid is normally palpable with no RUI. So this lady is coming to you with thyrotoxicosis, symptoms of thyrotoxicosis. So you go for a thyroid function test. So you see that the TSH is suppressed at 0.01. The T4, this is the T4 in after delivery. So this you should consider as higher side, because the cutoff is usually between 12 to 14. So this woman has thyrotoxicosis. So what is the difference between thyrotoxicosis and hyperthyroidism? So hyperthyroidism is a condition where there is increased production of thyroid hormones from the thyroid gland. It can be because of Graves' disease, toxic multinodular goiter, autonomous functioning thyroid nodules, etc. Thyrotoxicosis is a condition which usually is not due to overproduction of thyroid hormone. It usually results from excess supplementation or because of destructive thyroiditis. So in this situation, we need to decide whether this woman has thyrotoxicosis. We need to decide whether we need to treat her or not. So again, we repeated her thyroid function test after 2 weeks. Her TSH this time comes as normal at point 0.2. The T4 has come as normal. So this woman is confused. The doctor is confused. She's not happy with the reports. She goes for a thyroid function test repeat after 4 weeks. This time it comes at the total opposite end of the spectrum. The TSH is more than 100, hypothyroid, low free T4 at zero point 0.6, and the TPO antibody is positive. So what are we dealing with here? So this is a classical case of postpartum thyroiditis. So, what is postpartum thyroiditis? This is a destructive thyroiditis, which is usually seen in women having autoimmunity, especially the TPO antibody positive. It has many phases. It can go through many phases. Like the classical one is the biphasic one, where there is a destructive thyroiditis. Like in this lady, there is the TFT shows thyrotoxicosis. Later, it returns to normal and then goes into the hypothyroid range. And this woman can become normal in 8 to 12 months or continue to be hypothyroid. Then there can be the transient hypothyroid phase, which can return to normal, or the persistent hypothyroidism phase first detected in after delivery. Again, the woman can have transient hyperthyroidism alone, which can return to normal. So monitoring every 4 to 6 weeks is very important. So in this lady, we would monitor in the thyrotoxic phase. Again, we would go for one thing I forgot to mention is that we would go for a TSH receptor antibody in this case to differentiate between Graves' disease and the postpartum thyroiditis, just like we did in to differentiate between gestational thyrotoxicosis and Graves' disease. So the TSH receptor antibody will invariably come as normal. So this is a case of postpartum thyroiditis. So how do we differentiate postpartum thyroiditis from Graves? Again, this is a very common condition seen in 4% of women post-delivery compared to Graves, which is only around 0.2 percentage. The time of onset is typical. It occurs between 3 to 8 months after delivery. Usually Graves' disease comes after 6 months of delivery. Thyroid enlargement or goiter is usually seen in Graves' disease, but can be seen in postpartum thyroiditis. Bruit and exophthalmos are more commonly seen in Graves' disease. TSH receptor antibody positivity is more commonly seen in Graves' disease, though there can be slight positivity in postpartum thyroiditis, though the titer might not be very high. Because this is a destructive thyroiditis, you will see high level of thyroid peroxidase positive antibodies, and both of these are autoimmune etiology. How do we treat postpartum thyroiditis? So this requires frequent monitoring. If you are finding the patient in the thyrotoxic phase, you just require beta blockers or no treatment. If the symptoms are very mild, monitor the thyroid function test. If you are finding the patient in the hypothyroid phase, better to treat with thyroxine. Frequently monitor therapy in those who are having transient hypothyroidism. Usually the TSH returns to normal or even comes on the lower side, wherein you have to taper the dose and stop. Sometimes you will be dealing with frank hypothyroidism, wherein you will be requiring lifelong thyroxine replacement. So this again requires frequent monitoring to confirm that the patient is having permanent hypothyroidism. And also for the treatment, you need to monitor the thyroid function test initially every 4 to 6 weeks. And once the dose is stable, you can monitor every 3 to 4 months. So with this, I'll be concluding the session. So thank you all for the patient listening. Any questions or queries, I can take those. These are my references I have used. So thank you once again. So I can see a good number of attendees. So if any questions, you can directly ask or you can put in the chat box.
പാർട്ടിസിപ്പൻസിനെ അൺമ്യൂട്ട് ചെയ്ത് ഡൗട്ട്സ് ചോദിക്കാം.
Yes, I think there is one question from Dr. Someone has raised the hand.
Uh, Patient
Yeah.
on neomercazole going to hyper. Tony, can you read that?
Yes. So,
That
neomercazole
patient on
hypothyroidism
I will
is
read the.
that after
I will
stopping the,
read the question.
yeah.
Patient on neomercazole going to hypothyroidism. Is there any need to give thyroxine replacement after stopping neomercazole?
So actually, see, if you should plan the your treatment. If it is a Graves' disease treated before pregnancy, you should try to make her euthyroid even before pregnancy. Leave a gap of 6 months to 1 year before pregnancy. Make her euthyroid. Sometimes what I have seen is that physicians look at just the TSH to treat Graves' disease or people having hyperthyroidism, and this is not a good way of treating thyrotoxicosis because once the TSH becomes normal, the patient might already be in hypothyroidism. So always be careful when you're treating a patient having Graves' disease or any hyperthyroidism. As I've said earlier, keep the T4 or the free T4 at the upper end of the reference range. So the free T4, I would say keep it around 2 or 1.8 to 2. The total T4, keep it between 18 to 20 microgram. So in that way, you will prevent a woman, the fetus actually going into hypothyroidism. We are more concerned about the fetus here. As I've said in my talk repeatedly, the fetus and the mother both can tolerate thyrotoxicosis, mild thyrotoxicosis, but they are more susceptible, the fetus especially is more susceptible to hypothyroidism. So in your patient, if you have overtreated and this patient becomes hypothyroid, it means that the developing fetus is also exposed to low thyroid hormones. There is no consensus as such in this situation, but you should first stop the neomercazole treatment, and you can consider giving a very low dose thyroxine like a 25 microgram or even up to 50 microgram, maybe for 1 week, and repeating the thyroid function test. This would be how I would be managing. You can also go for just stopping the neomercazole and just monitoring the thyroid function test.
There is another question. Is it necessary to test fasting or early morning TSH levels in pregnancy?
See, that depends on whether this woman is treated or not treated. So, in women who are already treated for hypothyroidism or thyrotoxicosis, you are taking over the circadian rhythm with the drug. So you can test at any point of the day. But in untreated women or women without a history of thyroid illness, better to check in the morning because there is a circadian rhythm to the TSH, which usually is like it is normal in the daytime. Towards the night, it can reach a nadir. So better to test in the daytime.
Uh, Another question is, if TST is normal in first trimester, is it necessary to recheck it in the second and third trimester?
No, it is not necessary to recheck unless you are having new symptoms of hyperthyroidism or hyperthyroidism. So if the TFT is normal in the first trimester, there is absolutely no indication to check. If the woman is on antithyroid drugs or levothyroxine, like you have to check every 4 to 6 weeks. In thyrotoxicosis, you have to check every 2 to 4 weeks.
Another question, in pregnant patients with the TSH more than 4, do we have to do anti-TPO antibody before starting on levothyroxine?
So, my clinical practice is I would start levothyroxine in any woman with a TSH more than 4. Though you can consider not to treat these patients also. If these women are TPO antibody positive, then definitely you have to treat. But sometimes you see patients referred to you with a TSH of 4.2 or 4.5 or even up to 5, and you tell the woman that you are having mild hypothyroidism. They will say, my thyroid function test was normal earlier. In these situations, you can consider rechecking the TSH after 1 or 2 weeks. If it's still on the higher side, more than 4, then you can consider treating with very low dose thyroxine. In my clinical practice, I usually start with levothyroxine 25 microgram, anyone with a TSH more than 4.
Participants can unmute and ask questions. There is another question. How often should patient on neomercazole be checked for agranulocytosis?
So agranulocytosis is a rare idiosyncratic reaction to neomercazole or carbimazole. Neomercazole is the brand name, carbimazole is the drug. So it is an idiosyncratic reaction. So there is no recommendation to check the blood counts whether the patient is developing agranulocytosis or not. However, we should warn all patients, be it pregnant or non-pregnant, that if you are developing fever with sore throat, you need to come back immediately, stop the antithyroid drug, come back immediately, do a blood count, and if it is normal, they can restart their medication. If it is coming on the lower side, then you can suspect a granulocytosis and treat accordingly.
Another question is, what is the starting dose of propyl thiouracil?
Okay, see, propyl thiouracil usually comes and in 50 milligram tablets. So if you look at equivalent doses of propyl thiouracil to carbimazole, I would say that 50 milligrams of propyl thiouracil would roughly be equivalent to like 5 milligrams of carbimazole. So the starting dose, it's not you have a fixed starting dose. Just like in hypothyroidism, you look at the thyroid function test, whether you are having frank hyperthyroidism or subclinical thyrotoxicosis. Even as I said earlier, if the free T4 is just at the upper limit of normal or just above the upper limit of normal, you need not treat these patients. You look at the maternal symptoms also, whether she's having thyrotoxic symptoms like weight loss or inability to gain weight, tremors, hyperdefecation. You look at all these and then you decide on treatment. When you treat pregnant women, you have to start on the lowest possible dose of antithyroid drugs, be it PTU or methimazole or carbimazole, and then titrate every 2 to 4 weeks. So this, I would say, would depend on the thyroid function test, but a dose in pregnancy between like 50 to 200 milligrams per day would be adequate. I would recommend start at a low dose, maybe like 100 milligram per day, like 50 milligram in 2 divided doses, and then titrate as per the thyroid function test to keep the T4 at the upper limit of normal. Don't look at the TSH when treating thyrotoxic patients. That is the key message here.
Another question is, what is the ideal time to take levothyroxine?
So the ideal time, I would say, would be after 8 hours of fasting in the morning. If that is what the question is, you have to take it in the morning, empty stomach, after 8 hours of fasting. And after taking the tablet, you should wait for 1 hour before taking any tea, coffee, or any food. Also, you should space your tablets. That is very important thing in pregnancy. Usually, they will be on multivitamins, calcium, iron. All these interfere with the thyroxine absorption. So it's very important to give these tablets later on in the day. I would prefer giving them in the afternoon or in the evening time, keeping thyroxine separate in the morning, empty stomach.
In infertility patients, can we start thyroxine if TSH is more than 4? Any guidelines?
Definitely, definitely. See, the guidelines, the ATA guidelines, they recommend to keep the TSH less than 2.5 in individuals who have had a previous abortion or who are having infertility. So this is more so in ladies who are having TPO antibody positive, even in TPO antibody negative individuals who are having TSH of say 4 or above, it is better to treat and keep it below 2.5.
What is the maximum dose of neomercazole and PTU and starting dose of PTU?
See, there is no, I would say the maximum dose of neomercazole would be like up to 50 to 60 milligrams. But usually people who don't respond to 20 to 30 milligram will not respond to a higher dose. You look at the thyroid function test first. The usual starting dose in very frank thyrotoxic patient with neomercazole or carbimazole is with 20 to 30 milligram. You look at the thyroid function test. If it is still the T4 and T3 are coming down, you will not increase the dose. Okay, you are not looking at the TSH here. If the T4 and T3 are coming down, you will keep at the same dose, or maybe even if you are seeing a 25 to 50% decrease in the T3 and T4 compared to the baseline, you will actually reduce the dose. The maximum dose, I would say, would be between 50 to 60 milligram, though increasing the dose more than for 30 or 40 milligram does not add any incremental benefits. For PTU, I would say the dose would be somewhere between 100 to 400 milligram, again, depending on the thyroid function test.
Another question, patient taking thyroxine, TFT done with or without taking thyroxine?
So this is a very common question, both asked by the physicians and patients. So should I take my daily morning thyroxine tablet? So the answer, it doesn't matter. Okay, what you should know is that thyroxine has a half-life of 7 days. So the test you are doing right now, it is reflecting the thyroid supplementation that was done in the last few weeks. It's not the current day. So the only thing that would increase, see, if you are treating a hypothyroid patient and you are just looking at the TSH, it doesn't matter whether you are taking the thyroxine or not taking the thyroxine. But if you are doing a thyroid function test fully, usually what you see is that the patients come with complaint that TSH is normal, but T4 is high. Why is the T4 high? This is the thyroxine that you have taken. Okay, so you should know to interpret the test. So whenever we see such patients, we just ask them, did you take the thyroxine before going for the test? If they say yes, then it is a part of just it is just the thyroxine that the patient has taken. So hypothyroidism, do a TSH irrespective of the time of the day because the patient is already on thyroxine.
Okay. Another question is when to check for TFT after delivery on on a patient who is on thyroxine.
So, see, there are two scenarios. One is a woman who had pre-existing hypothyroidism. So, you will decrease the dose to the pre-pregnancy dose, and you will check the TSH after 4 to 6 weeks. This is the ideal time to check. Again, a woman who is newly diagnosed with hypothyroidism in pregnancy, it depends on her dose, her TPO antibody status. Usually, women on a dose of say 50 microgram or less, you can consider stopping the tablets altogether and checking after 6 weeks to see whether the lady really has hypothyroidism. I would say if this patient has a TPO antibody positive, I would go slow. I would reduce by 25 micrograms from 50 to 25. And the next visit, if still the TFT is coming normal, I would consider stopping the drug. But any dose more than 50 started in pregnancy, better not to stop the drug altogether, reduce by 25 micrograms, and check the thyroid function test after 6 weeks.
പാർട്ടിസിപ്പൻസിന് ഡൗട്ട് ഉണ്ടെങ്കിൽ അൺമ്യൂട്ട് ചെയ്ത് ചോദിക്കാം. ക്വസ്റ്റ്യൻസ് ആരും പുതിയതായിട്ട് ടൈപ്പ് ചെയ്തിട്ടിട്ടില്ല. ആർക്കെങ്കിലും കൂടുതൽ ചോദിക്കാനുണ്ടോ? ഡൗട്ട് ചോദിക്കാനുണ്ടെങ്കിൽ ചോദിക്കാം.
I hope I had made the thyroid disorders in pregnancy simpler.
Yes. ഓക്കെ, എന്നാൽ നമുക്ക് വൈൻഡ് അപ്പ് ചെയ്യാം. താങ്ക് യു ഡോക്ടർ ടോണി ഫോർ sparing your valuable time
Thank you.
to enlighten the doubts of our more physicians and most gynecologists who participated more in this session. Thank you once more on behalf of KGMOA Academic Cell. Thank you very much. We'll end up in the session.
Thank you, Dr. Abhilash, and thanks KGMOA for giving me this opportunity.
Okay, thank you. Thank you, Tony.
Okay, thank you.